Okay, Assalamu alaikum everyone. So today we are going to start endocrinology module, in which we are going to start embryology first, in which there is this thyroid development topic. Okay, so how is thyroid basically developed? It arises from a diverticulum, which is a thyroid diverticulum, right? After that, and that thyroid diverticulum arises from the floor of the primitive pharynx, right? And then it descends into the neck, like the thyroid's original location, right? It is connected to the tongue via a duct which is called as a thyroglossal duct, right, which normally has to disappear, right? But if it persists in your neonatal life, so it will be it will persist as in the form of a cyst or a lobe of the thyroid, an extra lobe of the thyroid, which will be called as a pyramidal lobe, right? Then you need to remember that what is the normal remnant of thyroglossal duct, right? So the normal remnant is foramen cecum. This actually comes in MCQ, right? Most common ectopic thyroid tissue site is the tongue, that is the lingual thyroid, that is also an MCQ. And removal may result in hypothyroidism. Obviously, the thyroid levels, thyroxine will be low, and it will result in hypothyroidism, right? Okay, so the thyroglossal duct cyst, that basically presents, how it presents? It presents as a midline neck mass, right? And you ask the patient to swallow, then that mass will move with swallowing. If or you ask the patient to protrude the tongue, in that case also it will move with swallowing. So that is a thyroglossal duct cyst then, right? Then you need to remember two things which are MCQ point of view important. So the thyroid has got two types of cells. We know follicular cells and parafollicular cells. These follicular cells are the main cells of it, and they are basically derived from endoderm, right? While the parafollicular cells are derived from the pouch, pharyngeal pouch. Which one? Fourth pharyngeal pouch, right? You need to remember this, fourth pharyngeal pouch, parafollicular cells, right? So that was embryology. Now comes anatomy of endocrinology module. So first of all, we will discuss about pituitary gland. It has got two types: anterior pituitary adenohypophysis and posterior pituitary, also called as neurohypophysis, right? Okay, so in case of anterior pituitary, you need to remember that is being derived from ectoderm, right? Ectoderm. Okay, it secretes which hormones? So you need to remember that by a mnemonic, right? So these are the hormones: flat pig, FLATPIG, right? You need to remember like this. F say FSH, then LH, right? Then ACTH, then TSH, right? And then from pig, it's P say prolactin, G say growth hormone, right? Okay, so it secretes basically all these important hormones, and other than that, beta endorphin and MSH, that is melanocyte stimulating hormone, as well. They are secreted from the intermediate lobe of pituitary, right? And they are derived from oral ectoderm, as I already have told you, ectoderm, right? Also a rat case for this MCQ was there in the paper, that the embryological derivative is rat case pouch, which is also the oral ectoderm called, right? It has got two subunits: alpha subunit. Alpha subunit basically is a hormone subunit, right? Hormone subunit, which is common to all these four hormones, right? It's TSH, LH, FSH, and HCG. They all have got the same alpha subunit. While the beta subunit, it is different, and that basically determines hormone specificity, right? Then comes posterior pituitary. Before we start it, I need to tell you that propiono-melanocortin derivative is beta endorphin, right? Along with that, ACTH and MSH, right? Mnemonic is go pro with a BAM. So propio-melanocortin derivative, right? What is it? Beta endorphin, ACTH, and MSH. These three. B flat are acidophils. ये जो the first one, the first mnemonic was flat pig, right? They were released from anterior pituitary along with that of the other two, that is beta endorphin and MSH, right? Now what are acidophils and what are basophils, right? You need to remember only acidophils. The rest ones are the basophils. So acidophils, acid pig, only the pig, that is a prolactin and growth hormone. These two are only acidophils. The rest of them are basophils. So remember only two, and the rest you will remember by yourself. Posterior pituitary is also called as neurohypophysis. So it stores and releases vasopressin, which is also called as an ADH, anti-diuretic hormone, as well as oxytocin. So posterior pituitary releases two hormones, ADH and oxytocin, and they both are made where they are made. They are made in the hypothalamus. Which nuclei? Supraoptic and paraventricular nuclei, and then they are transported to the posterior pituitary via neurohypophysis. These are basically the carrier proteins. And from where this posterior pituitary is being derived, this, as it's a neuro, whenever there's a neuro component, it's derived from a neuroectoderm. Both are derived from ectoderms, but this is from neuroectoderm and this is from the Rathke's pouch, that is oral ectoderm, right? Okay, I hope till here it's clear. Next comes the adrenal cortex and medulla. So adrenal cortex, it is derived from mesoderm. So this is a different thing, so you need to remember this, that the cortex, the outer portion, this one, this is cortex, right? And the inner one is medulla. So the cortex is derived from a mesoderm, while the medulla is derived from neural crest cells, right? NCC, neural crest cells. You need to remember these two things. Other than that, there are basically 3 layers of cortex, and medulla has got chromaffin cells. So the 3 layers of cortex, on histology we can see the outer okay, so you remember it by GFR, right? GFR, you know, in the kidney, you remember this GFR, glomerular filtration rate. So GFR here stands for G, glomerulosa, zona glomerulosa, right? G, then F, fasciculata, and then R, that is reticularis. So zona glomerulosa, what it is, it basically the classic hormone which it secretes is mineralocorticoids, right? And what is that hormone class is mineralocorticoid, and what is the first hormone? That is aldosterone, right? And it is primarily regulated by angiotensin 2. So this actually also comes in paper, that aldosterone is primarily regulated by which hormone? That is angiotensin 2. Okay, the next one, the next layer is fasciculata, F. That basically releases glucocorticoids. The hormone main is cortisol, and that is being regulated. We know that hypothalamus CRH secretes ACTH, and then it secretes cortisol. Okay, so CRH and ACTH. Again, the next one is reticularis, that is also primarily regulated by ACTH and CRH. They basically secrete androgens, and the first hormone in the androgens is DHEA, dihydroepiandrosterone, okay, yeah, or androsterone. Okay, so the 3 ones were mineralocorticoid, glucocorticoid, androgens from GFR respectively, right? What about the chromaffin cells? They basically are the preganglionic sympathetic. Remember this MCQ, this is very high yield, that we know that sympathetic fibers are divided into preganglionic and postganglionic fibers, and most of the organs, they receive the postganglionic things, but this adrenal medulla, they receive directly the preganglionic sympathetic fibers, and the hormone classes catecholamines, which they release epinephrine and norepinephrine, and the hormones, right? So GFR, remember, like salt, number 1, mineralocorticoids, sugar, glucocorticoids, and sex androgens, right? Salt, sugar, and sex. Okay, the next one is endocrine pancreas cell types. So we know the pancreas is being divided, has got different types of cells in it. Isles of Langerhans are collections of alpha, beta, and delta cells, endocrine cells, and they basically rise from pancreatic bud. So you can see in the MCQ in the picture, this is these are the alpha cells, yellow in colors. These alpha cells are basically responsible for secreting glucagon. They are located peripherally. Okay, then the beta ones, look this, beta ones are located centrally, so they release. Beta cells of the pancreas secrete insulin. Then the delta cells, these are the delta cells, the big ones. So they are interspersed in between the alpha and beta, cells, and they release somatostatin. So alpha, beta, delta, glucagon, insulin, and somatostatin. Okay. Now this table, this is very important, that hypothalamic pituitary hormones, all of them are listed here, and you'll get the details in the later topics. But from the very start, you need to remember these, this holistic thing. Okay, so we start from ADH. We know their functions are basically there in some of the clinical notes. Okay, so ADH, that increases water permeability and distal convoluted tubule in collecting duct cells के अंदर, यानी कि it basically increases water permeability, right? So in the kidney to increase water reabsorption. I'll tell you in the detail in the later topics. Basically, ADH anti-diuretic hormone, like it prevents diuresis, which is excessive hormone loss. Water loss. When it will prevent this water loss, then how it will prevent water loss? By increasingly absorption of water, right? Increasing its water permeability. So when there is more alcohol consumption, there will be decreased ADH secretion. So this is one correlation, and decreased ADH secretion will definitely lead to its opposite effect, like diuresis, that is polyuria, and then of course dehydration. Then comes CRH, that is cortical releasing hormone. Okay, what is it? That basically the function is basically CRH is released from the hypothalamus, and that basically increases ACTH in the pituitary, right? Along with that of ACTH, it also causes increase in the other two, that is beta endorphin and MSH, melanocyte stimulating hormone. Why? Because these three were basically has got the same derivative. Remember pro melanocorticotrophin, right? In the previous page we have discussed. So when this clinical notes included, this CRH would be decreased in chronic glucocorticoid use. So when a patient is in chronic steroid use, then this CRH would be decreased. Okay, next is dopamine. So dopamine's main function is to inhibit prolactin, right? It's an inhibitory hormone for prolactin. And also along with prolactin, it also decreases TSH, thyroid stimulating hormone, right? This dopamine is also called as prolactin inhibiting factor, as I already have told you. And the things which basically antagonize dopamine, the dopamine antagonists, for example the antipsychotics, they can obviously cause increased prolactin and galactorrhea due to hyperprolactinemia, right? Then comes the GHRH, growth hormone releasing hormone, that basically increases growth hormone, and its analog is one of its growth hormone analog is this tesamorelin, used to treat HIV associated lipodystrophy. Okay, so this is used to treat HIV associated lipodystrophy, GHRH analog. Then comes GnRH, that is gonadotrophin releasing hormone, that basically when is increased, that released, that stimulates the release of FSH and LH from the anterior pituitary. And when there would be hyperprolactinemia, right, this is suppressed. GnRH would be suppressed when there would be hyperprolactinemia, and when it basically occurs in the lactational period after the delivery of the baby, right? Then comes the next thing, which is tonic GnRH analog, and then pulsatile GnRH. Okay, so the tonic GnRH analog is leuprolide. It basically suppresses this whole axis, hypothalamic pituitary gonadal axis, right? Pulsatile release of GnRH actually is responsible for the puberty and fertility, right? It basically released in pulses, that is okay, but the tonic one, that suppresses this axis, like, okay. Then comes MSH, that is melanocyte stimulating hormone. It basically, obviously the name indicates, increases melanogenesis by melanocytes. And what does they do? These are basically the cells which cause hyperpigmentation in our skin. And in Cushing's disease, remember this disease word is like when the when the increase in cortisol is because of the primary pituitary pathology, right? Then it is called as Cushing's disease. So it causes hyperpigmentation in Cushing's disease, as MSH and ACTH, they both have the same precursor, as I already have told you, pro-opiomelanocortin. Okay, so oxytocin. Next is oxytocin. Oxytocin causes uterine contraction during labor, and also for milk letdown reflex. This is MCQ, milk letdown reflexes by oxytocin, and it modulates the fear, anxiety, social bonding, mood, and depression. Prolactin. So prolactin basically decreases gonadotrophin releasing hormone, and it stimulates lactogenesis, right? Like in the period after delivery. So if there is any kind of adenoma in the pituitary glands, pituitary prolactinoma, that will release more prolactin, and as a result of which amenorrhea would result, right? Osteoporosis, hypogonadism, increase in the milk production, that's galactorrhea. In the breastfeeding period, I already have told you, there would be increased prolactin that will inhibit GnRH. So this MCQ comes in the period of breastfeeding, why the patient is having amenorrhea, because there is increased prolactin and that is inhibiting GnRH, so there would be amenorrhea. The patient won't get her periods. Okay, so decreased GnRH would lead to delayed postpartum ovulation, obviously no menses, and that is a way of natural contraception. Okay, then comes somatostatin. Somatostatin basically inhibits growth hormone along with that of thyroid stimulating hormone, TSH, and it is called as growth hormone inhibiting factor. And this also comes in MCQ, okay, which thing basically inhibits growth hormone, that is somatostatin. TRH is thyroid releasing hormone that causes release of TSH and prolactin. Have you noticed that this TSH and prolactin, they're coming like hand in hand? Remember this TSH and prolactin here. TSH and prolactin, the inhibitory factor was dopamine, which were inhibiting the two, and the stimulating factor is TRH, which is stimulating the two. So remember, these two are coming hand in hand, thyroid and prolactin. Okay, then this TRH, for example, in primary, TRH would be raised in primary or secondary hypothyroidism, obviously as a reflex mechanism, and that may also increase prolactin secretion, as I already have told you, leading to galactorrhea. So this was all about it, and these are indicated that these two were acidophils. You remember this growth hormone and prolactin, they were acidophils, while all others were the basophils, basophilic, ACTH, LH, FSH, and TSH, which were released. These are all released from anterior pituitary. The above ones were from the posterior hypothalamus, and then it's being shown that this CRH basically stimulates ACTH, GnRH, FSH, TRH, along with that of TSH. Also, you can see this prolactin, right? GHRH, growth hormone, dopamine, inhibits prolactin, right? This is something very important. This prolactin, you can see that inhibits G and RH. So this was something, and you need to remember. And also this somatostatin, right? What it did, it decreases GH and TSH. So somatostatin was inhibiting TSH along with that of GH. So this was the short term thingy, right? Right. Also some important MCQ point of view related to FCPS part 1. GnRH, that is gonadotropin releasing hormone. I've already told you tonic GnRH analog leuprolide will suppress the axis, while pulsatile will increase fertility and puberty. This GnRH has got the shortest half-life. Okay, you need to remember this. Then this gonadotropin releasing hormone. Okay, the positive feedback, for example, GnRH released by estrogen. Okay, some of the MCQ. Okay, so next one is growth hormones. So we already have started physiology, right? I've told you about the pituitary, hypothalamic pituitary axis, all the basic hormones. Now we are starting one by one all the hormones. Like the first one is growth hormone. Already have started physiology, right? Okay, so the first one is growth hormone. It is also called as somatotropin. Okay, it is secreted by anterior pituitary. Already know. Stimulates linear growth and muscle mass. It stimulates linear growth and muscle mass by what? By IGF-1. That is basically insulin like growth factor 1. It is also called as stomatomedin C. These both are the two in one and the same thing, two names for one thing. Okay, so IGF-1, right? Stomatomedin C, it is secretion basically through liver. It is secreted through liver, and it stimulates linear growth and muscle mass through IGF-1. Okay, the next thing it causes, growth hormone increases insulin resistance. That is, it can lead to diabetes. It is diabetogenic. Why? Somebody asks you the why growth hormone is diabetogenic. It increases insulin resistance, right? It is released in pulses in response to growth hormone releasing hormone GHRH. So pulsatile release is important, right? And whenever you are sleeping and there is hypoglycemia, there is any kind of stress, there is puberty, there is exercise, you're doing exercise. So in all these situations, its secretion is increased, right? You need to remember this. But primarily increased by hypoglycemia. So this also came in MCQ, that growth hormone secretion is increased by which of the following factor most importantly. So among all these, hypoglycemia, when is there, it will increase growth hormone secretion. Okay, then the secretion is decreased with as you age. There is obesity, there is increased glucose in the blood, somatostatin, which is its inhibitor, stomatomedin, which is also regulatory molecule, which is secreted by liver in response to GH acting on the target tissues. Already have told you this stomatomedin C, IGF-1 secreted by the liver because of this growth hormone. Okay, then excessive secretion of the growth hormone when is there, for example, when there is any kind of pituitary adenoma, then growth hormone will be excessively released. That causes acromegaly in adults and gigantism in children, right? Disproportionate bone growth, which is gigantism. How will you treat this condition of increased excessive growth hormone? Somatostatin analogs, of course, which is basically its inhibitor, that is octreotide, or surgery is also advised. So it also causes increased level of fatty acids in the blood. So you can also see the metabolic things in the picture, which are very important. This GHRH, growth hormone releasing hormone, that releases along with that of somatostatin is basically inhibitory, right? So this GHRH, that causes release of growth hormone from the anterior pituitary. This growth hormone from the liver stimulates IGF-1, that is insulin like growth factor 1. Okay, then this IGF-1 does is that on the bones it basically increases amino acid uptake and make protein because of which. So protein synthesis is increased, DNA RNA is increased synthesis, chondroitin sulfate is increased, right? Collagen is increased, cell size and number is increased. Because we have to do the linear growth of the bone, so all of these things are increased. Then on the muscle also positive effect, amino acid uptake or protein synthesis is increased, right? What about the fats, right? About the fats that and on the fats and carbohydrate metabolism, it decreases glucose uptake by the cells. That is why we said that it is diabetogenic. Decreases glucose uptake by the cells, that's why it increases in the blood and causes diabetes. And lipolysis, that is it breaks down the fat, right, into big fats into smaller fatty acids. Lipolysis ko zyada karta hai, so it increases the level of fatty acids in the blood. Okay, Then comes the ADH hormone, antidiuretic hormone. It's also called as vasopressin. We already know that. It is synthesized in the hypothalamus by supraoptic and paraventricular nuclei. It is then stored and secreted by the posterior pituitary. We already know that function. It basically regulates our blood pressure via which receptors? V1 receptors, and serum osmolality via which receptors? V2 receptors. So these are the MCQs. Blood L1, so V1, right? Blood pressure by V1 receptors and serum osmolality by V2 receptors. Primary function is serum osmolality regulation, right? So whenever there is ADH, it basically decreases serum osmolality and increases urine osmolality, right? How? By regulation of aquaporin channel insertion in the principal cells of the renal collecting duct CD. So always remember the sequence that ADH acts on CD first, that is collecting duct. I've remembered this, like ADH is a mnemonic abbreviation, ADH. So it ADH, it's an abbreviation, right? ADH. So it also there's an abbreviation CD. So ADH basically acts on directly on the renal collecting duct CD, while on the other hand angiotensin 2 is left, so that acts on the CCT, that is cortical collecting tubule. Okay. The CD, this actually comes in MCQ, and its main primarily function is very important, that is it decreases serum osmolality while increases urine osmolality, right? Next is basically that ADH level is decreased in central diabetes insipidus, right? And it is normal or increase in nephrogenic diabetes insipidus. That's how you remember you differentiate between the two. Nephrogenic diabetes insipidus can caused by mutation in the V2 receptors. Like V2 receptors we know were located in the kidneys. V1 receptor is located in the blood vessels for blood pressure regulation. So this V2 receptor is basically main in the kidneys, and that is responsible for this nephrogenic diabetes insipidus, right? Where there is not the problem of ADH, but the receptors are mutated, right? So nephrogenic diabetes can be caused by mutation in the V2 receptors. Then there is this the friend of ADH, that is ADH analog, that is desmopressin. It's used for the treatment of central diabetes insipidus, because I've told you ADH level will be decreased in central diabetes, so we have to give its analog, that is desmopressin, right? Or what? Even in nocturnal aneurysms, some people complain of, also we can give this desmopressin, right? Then comes this is also a potent vasopressor. Vasopressin is also potent vasopressor, as the name indicates, that can be used to increase organ perfusion in septic shock. This one point you need to remember. Okay, so the video has got a little longer, so we will do this from here onwards. We'll do it in the next lecture. This from prolactin I'll start in the next lecture. So yeah, if you like the video, do like, share and subscribe with your friends. Hit the notification icon so that you can get my daily video series. Okay, thank you so much for watching. Take care. Allah Hafiz.